Cool.
Nice.
Okay. So I'll wait for everyone to log in. I might just log in from my phone as well, so we have at least 3 players. Obviously, I'm not going to answer all of them correctly because I literally have the answers in front of me. 5, 2, 1.
If you guys have any questions, just feel free to unmute or whatever. About
Third out
either
of
these
3.
questions or about second year, about life in general. It's all good.
Yeah, honestly, like, I don't know, it can be anything. What's your favorite TV show? What are you watching right now? Like, it doesn't have to be study related, and you can interject at any time. Like, we're happy to answer questions even while the question is running. Okay, cool. I think we have everyone. Yajat, Deepak, I'm assuming that means you don't want to be part of the game. Oh, okay, never mind. We got some competition here. Let's get started. So let me just start the game. Oh, actually, music. Let me share with sound. Okay. Give me 1 sec. Sorry about that, guys. Okay, can you guys hear that? Was that?
Not really, no.
No? That's annoying. I've got it on full. That's okay. If the sound comes up in the middle of the game. Yeah, do you guys? Yeah, it's okay. I think we'll just get started just for time's sake. If it starts in the middle of the game, that's cool. Hear it now? Yeah.
That's me. Sorry.
That's so loud. Oh my god. Okay. Which of the following antibiotics is bactericidal? So a bit of a definition one to start off with. Cool. Okay. Most of us, I mean, all of you got the correct answer. This wasn't my question. Was this yours, Yaja?
No.
Or someone else's here? Nah? Okay. I think this one is fairly just like, memory-based stuff. Everything else here is probably like a bacteriostatic. So remember the difference, bactericidal meaning you're actually physically killing the bacteria, either by, for example, rupturing the cell wall or like similar mechanisms, so directly killing. Whereas bacteriostatic would be stopping processes within the bacteria itself that prevents them from actually growing and replicating. So for example, stopping protein synthesis, etc. So very, very good. Amoxicillin is the only one that's bactericidal. All right, next question. In which of the following situations is treatment not generally indicated? Acute severe rhinosinusitis, bronchitis in an unvaccinated 1-year-old, viral tonsillitis, or otitis media in an ATSI patient? Awesome. Okay, so viral tonsillitis. Again, I'm not sure if anyone, the person who actually put this question up is here, so I might just explain as much as my knowledge permits. Viral tonsillitis is, I think, as long as it's not, a lot of these, as long as they're not like severe infections, you can kind of have a waitful watch sort of approach, because a lot of them will be self-limiting. So in this case, viral tonsillitis is one of them. Generally, rhinosinusitis is something that you would wouldn't treat. The only thing is that because it's acute severe, we're kind of having red flags that potentially this is something that will require intervention. Same with otitis media, especially when you have it in a high risk population, is something that you definitely need to keep in mind, because we don't want that to get worse. Like for example, you could get like blue ear. It's not very pleasant to have an infection like that. Same thing with bronchitis. Things like these can get really, really bad really quickly. And the key sort of like thing to keep in mind here is the fact that they've given you specific demographics. So unvaccinated 1-year-old, definitely going to get worse. ATSI patient, that's your high risk population. So viral tonsillitis is the final answer here. Hope that makes sense. If there's anyone who has any questions, just let me know. But we'll move on to the next question. Well done to smiley face. Which of the following drugs is not part of the standard therapy for tuberculosis treatment? So there's a nice mnemonic that comes with this question, which we'll go over after the question is done. Amazing. So I guess the mnemonic itself can be a bit misleading. So if you only remember the mnemonic, it can be tricky to get the final answer because the mnemonic is RIPE. So RIPE. And all of the medications here do kind of have those letters. The only thing is that, yes, you have rifampicin, isoniazid, I can't pronounce these, pyrazine, blah, 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 whatever. Those are the medications. E is actually for ethambutol, not erythromycin. So that's the reason why this one is incorrect, which is why you can remember the mnemonic, just in case the letters don't match, but also a good idea just to have a think about what those mnemonic letters actually mean.
Do a pop quiz just there. What is one of the side effects that rifampicin has on your color of the urine? Just chuck it in the chat.
Or on mute. Yeah, fantastic question. What do we think, guys? Rifampicin and urine.
Nice. All right. Yep, that's correct. So it becomes reddish, orangish. The only reason I remembered this is because rifampicin starts with R, so I think red, and then it ends in pissin. So it works pretty well.
Exactly. Awesome. Well done to whoever answered that. And it's also just a good thing to keep in mind when you're analyzing someone's urine and you see that it's red, is not to instantly assume that this is a patient who's bleeding from in the urine. It could be medications that they're taking, literally could be because they're eating a lot of beetroot or something, like, something benign, and then you're considering bleeding. Awesome. You're on fire, smiley face, and well done to everyone else. So we've only got a 300-point gap. The tables could turn very quickly. Asthma patient with SABA puffer reports it's no longer sufficient. The report, this no longer prevents attacks. What is the appropriate therapy to step them up? In other words, what will we do next now that the SABA puffer does not work? Awesome. So was this Yajat, your question? Sorry, I saw you
No,
were
I'm
about
happy
to
to talk
answer.
about it.
Yeah, sure. Awesome.
I guess, yeah, in your first line with asthma, if it's mild, you just have your SABA as needed, which is your Ventolin, short-acting beta antagonist, whatever. And then when that's not sufficient, you add on an ICS, which is a inhaled corticosteroid, and you're also still having your SABA as needed, but the ICS is a regular dose daily. Then if we were to continue, if you could just exit out of the picture so I can see the options. You would then add on the LABA. So you'd go low dose ICS with the LABA as well, which is more long acting. And correct me if I'm wrong, Jainam, it was you never take the LABA by itself. You always had the ICS, or the other way around?
I think so. From what I remember, it was the corticosteroids that you can't take by themselves.
Yeah,
I think.
so the mask inflammation.
Mass inflammation. Yeah.
Right.
Also, I believe you're actually right though, Yaja. Like LABAs, if you take them by themselves as well, like if you overuse them and don't balance it out with a bit of corticosteroid therapy, what can happen is that you can downregulate the expression of beta-2 receptors on the lungs themselves. And then so these drugs won't be effective anymore. It probably is worth just looking this up though. I'll have a look and get back to you with a proper answer.
Fair enough. That's good. Yeah. The main thing that Monash likes is the ICS masks inflammation. So you always want the LABA with it. You then move on to a high dose ICS and LABA, so the blue option, and then you can add on your specialized therapies later on. And yep, just to clarify for people watching the recording, it's a beta agonist. My bad.
No worries. Awesome. Thanks for that, Yajat. We'll go to the next question now. Okay, so third out of third is now not third, they're first. Well done. We'll go to the next question. Which of the following is a correct danger or side effect of long-acting beta agonists? So from what I am remembering, I don't think that this is correct, right? Like long acting, the reason why I believe long acting beta agonists are not used in isolation is because of the fact that they downregulate and that they're like beta receptors and then therefore won't be effective anymore, or like it's life threatening for the patient. I think the masking of inflammation is more when it comes to corticosteroids, but this kind of goes back to the discussion we just had. So might be something for me to look up and clarify. But any thoughts, Deepak or Yajat? Because I think everyone here put yellow, so it might be something that I'm just missing.
Just looking it up, honestly, because I remember being confused about this last year. It's one or the other.
Yeah, so
Yeah.
I wrote this one. I'm pretty sure it's LABAs, but I may be wrong, so I'll have to double check.
Yeah, awesome. So that will
'Cause
be
to my understanding, ICSs actually do reduce inflammation, if that makes sense. Like they target more source because they're all in on your phospholipase A2, your COX2, like the actual pathways. Whereas I think LABAs are more at it's like downstream versus upstream effects, but I'm not sure. So we'll check.
actually, now that I'm
Yeah.
looking it up, I think you're right. So LABA
Okay, there we go.
monotherapy.
Excellent. We're all in agreement there.
Not that there was
So the
any doubt,
question is-
James, but LABA monotherapy may mask airway inflammation, so therefore can risk fatal or near fatal respiratory events. There you go.
Yeah.
So-
So Abdullah asked the question in chat. How do the beta agonists actually do the like how do they reduce inflammation in the first place? So they are, like we said, more downstream effects. So it's basically you don't need to know the details with these ones, I don't think, particularly. So obviously they're acting through your typical like sympathetic pathway. And the main way that they're going to do that in terms of intracellular effects is increased cyclic AMP production and protein kinase activation and less intracellular calcium. You do not need to know those things though. So like that's the mechanism. Again, you'll note that is not really talking about inflammatory pathways. We're not really lowering inflammatory mediators per se. We're mostly just talking about that. There you go, mask airway inflammation. Yeah.
The only thing is, I also saw this website. Can't verify whether it's actually, I don't know, correct or not, but they also say this. So downregulation of beta-2 adrenoreceptors, therefore they're not gonna, like SABAs won't be effective anymore, which is dangerous. But I guess it's kind of a combination of both. So whichever one you get in the exam, just pick that one. Don't think you need to really understand.
Did I include that as an option and say it was not?
No. Wait, let me have a look. No, you didn't. Yeah.
Yeah, sure. So I didn't mean to imply that this is the only danger of LABA. So there's definitely other things. So you're absolutely right. But the only one of these options that is an actual danger is that one. Did we go over which other ones cause which things?
As in which other asthma medications?
Which other
cause what?
medications mess with other things? Or,
No, we
why
didn't.
the
I
other
think that
answers
would
are
have.
wrong?
No, we didn't.
Just
Yeah,
talk
so just-
about the stepwise approach.
Yeah,
That's-
perfect. So yeah, just like really quick, for the sake of learning. So red is like immunosuppression is ICSs. So you want to be really careful of those because they cause local immunosuppression wherever you use them. And if you use them in the lungs, then that can be a big problem for your basically respiratory infections. So like lots of patients who get put on long-term corticosteroids have to actually be put on prophylactics for all sorts of diseases. Blue, they're a positive inotrope because they're a beta agonist. And that's why you don't use beta antagonists or beta blockers in heart disease for patients who have asthma, because you are doing the opposite of what you're trying to do here. And then green, anti-slut effects. So that would be your anti-muscarinics. Yeah.
I might just add one more side effect, which is worth knowing, is SABAs and their muscle tremors. Too much SABA, if you have too many Ventolin puffs in an acute exacerbation, then you can get like minute hand tremors, which in a life-threatening situation isn't your priority, but good to know.
Yeah, you might, for anyone who's watched the video that I made on the clinical exam of the RESP, you might remember me awkwardly putting my hands out and doing like shaking them. That's one way you can remember it. The fact that Janum was on camera doing this for absolutely no reason. It's because of those beta 2 agonist overuse and things like that. So yeah, definitely relevant to know all those side effects for your examinations too. All right, let's go to the next question. So this one is, which of the following is true of COPD but not asthma? So it's really important to know the difference between these. So chronic obstructive pulmonary disease and asthma. Why are they different? Yes, amazing. So again, everyone's picked the correct answer for A. Is this something that another person in the team has put the question through? Is this your question, James, or?
Yeah, this is another one of mine.
Okay.
So yeah, honestly, it's pretty straightforward, I think. So you get a productive cough in COPD, you don't get a productive cough in asthma. In both of them, there's a risk of hypoxia for obvious reasons, so sort of respiratory failure. Inflammation is important in both, and family history. So family history is an interesting one because, like with COPD, usually we think smoking, which is not really a family history thing. Like, I mean, technically, social history wise, if your parents smoked, you probably are more likely to smoke. But the real reason why we want to look at family history in COPD is that in rare cases, it is familial. So alpha-1 antitrypsase deficiency can lead to COPD. A little clinical thing. I don't know if this is, they probably wouldn't test this in year 2, but COPD in smokers typically happens near the top of the lungs. So it's almost like the bottom pneumonia where it usually happens at the bottom. COPD usually happens at the top of the lungs because you're smoking and the air entry is best there. So if you get COPD in the bottom of your lungs, then you want to start thinking about that genetic disease instead, because like it doesn't match your normal smoking pathology.
Awesome. Any questions from anyone else? Thanks, James, for that explanation. If not, I think we're good to move on to the next question. All right, 3rd out of 3rd is still on top. Let's see if we can beat that. Which of the following statements is least correct? So this is the question that was actually incorrect. So yellow should actually be clubbing of the fingers could be a sign of severe CO2 retention in COPD. I think it's been repeated twice at the bottom. Yeah, cool. So again, apologies for the fact that it's been repeated twice. In this case, I'll walk through each of the options separately just to give you an idea about why one of them is least correct. So firstly, hypothena eminence wasting could be a sign of an apical lung tumor. That one is potentially true because of the fact that the apical lung tumor could be compressing on your lower brachial plexus nerve root, so like C8T1, which eventually goes down if you think about like myotomes, or even if you think about like the ulnar nerve and what muscles it innervates in the hand. You can remember that the intrinsic muscles would be the hypothena eminence. So wasting could be a sign of that. But of course, it's not very specific to an apical lung tumor. The other ones, a fine tremor in the hands may indicate that the patient uses an asthma inhaler. I think we just mentioned that. So Yajat was talking about the fact that when you have a beta agonist medication, that can, I guess, present in a patient as a fine tremor. And one way that you can I guess make that a bit more obvious, because obviously fine tremors are fine by definition. You can put a piece of paper on their hands while it's extended out, and you can see the paper sort of vibrate a little bit, which indicates that they're having that tremor. With green, so hypertrophic pulmonary osteoarthropathy. So this one is the thing that I kind of mentioned fleetingly in the lecture, but I also mentioned not to get too scared if you test this on a patient and you're like, oh my God, their wrists are tender. That means that they must have lung cancer. Not the case, because you want to be thinking about some of the more common things like, oh, do they have a fracture of the wrist? Something really, really basic. Is there soft tissue swelling? But this could be a potential red flag for lung carcinoma, especially if you have these other signs like hypothena eminence wasting. Finally, this yellow one that should have been the clubbing and COPD, that one is actually just one of those like buzzword type things that I mentioned in the lecture, which is that clubbing has a lot of different causes, and it's not just rest related, it's also cardio, GIT. But the one thing you never want to say when someone asks you what the cause is for a resp, you don't want to say COPD, Like you can say that it is due to pneumonia. You could say that it is due to lung cancer. You could say it's due to cystic fibrosis, but never say COPD. And again, I couldn't really tell you exactly why that happens. I think it's actually relatively unknown or under-researched why you get clubbing anyways, but I thought I'd just emphasize that through this question.
I might just, could I just share my screen quickly?
Yeah,
for
sure.
causes of clubbing. Clubbing confused me so much because everything was told to cause clubbing, and the one time we were asked, there would be something that doesn't cause clubbing. So I've just pulled out my Anki from year 2, and I had one card on it. Okay, causes of clubbing, and the acronym is clubbing. So it's one of those acronyms that actually work. Yep. So overall, I don't think you'd really need to memorize this, but the main point of this is cardio, resp, and GIT. So cardio, your cyanotic heart disease. In GIT, your ulcerative colitis, biliary cirrhosis. It's coming up soon. Don't worry about it. And then infective endocarditis, also in heart disease. But the L is the important part, I'd say, which is in lungs. And you've got A, B, C, D, E, F. So abscesses, bronchiectasis, cystic fibrosis, don't say COPD, empyema, and fibrosis. So all of these are relatively lower yield conditions, except for maybe cystic fibrosis for year 2 level. But yes, don't say so COPD. And then also like celiac disease and random neoplasms, cancers around the body. So if you want to screenshot this, put it in Anki like I did, it can help, but it's not that important. But some concrete details on what actually causes clubbing, rather than just thinking everything and then getting that one question wrong that might show up.
Awesome. Thanks, Yajat. Awesome. I'll just share my screen again with the Kahoot. But well done. I mean, for everyone who like last minute when I gave that extra option, a lot of you still managed to pick yellow. So I'm really, really impressed by that. But for everyone who did pick blue, hopefully that makes sense in terms of why that wouldn't be, or that would be actually something you would see in an asthma inhaler overuse patient. All right. Next question. Which of the following signs on the respiratory examination is the most concerning? Again, a little bit subjective, but I want you to think about what all these signs could be indicating as the underlying pathology. Yes, amazing. Well done. So just to clarify for the red one, generally speaking, remember when we look for tracheal deviation, the way that we kind of think about that is we have the patient, we look at their neck and the trachea. We ideally want the trachea to be equidistant from both the clavicles because that tells you it's smack bang in the middle, which is normal. With yellow, can anyone actually type in the chat or unmute and let me know what kind of sign or like what's the actual official name for the sign that I've mentioned there? Starts with H. Yes, amazing. So I got a couple of responses for Horner syndrome. So maybe like a little extension to that. What is Horner syndrome? Why is that bad? Or why could it potentially be bad? What could it mean? Yeah, fantastic. So with Horner syndrome, it's basically just your sympathetics to like half your face. So unilateral side of the face gets denervated, which means you lose all the sympathetic tone on that side of the face. So you get dry skin because you don't have any sweating, drooping eyelid because the specific muscle or tissue that's holding the eyelid up is no longer working. And then of course, you're not able to dilate the pupil anymore. So it stays constricted. So all those things, if you want to think about it very easily, ptosis, anhidrosis, meiosis are the 3 sort of signs you're looking for, which confirm Horner syndrome. One of the reasons you can get sympathetic denervation is the fact that you've got an apical lung tumor that's pushing against that sympathetic chain going up to the head and neck. But of course, there's actually all sorts of reasons why you can get a Horner syndrome. That's just one of the more common ones. Just really, really quickly for the blue and green, you shouldn't really be able to palpate any of the lymph nodes. To be honest, I've never palpated one ever. So if you can palpate it, usually it's because it's enlarged, infected, tender, whatever. So generally it's normal to not feel it. And when you do muffled sounds through your stethoscope, that's actually normal. If you hear the sound too clearly, that could indicate some form of consolidation because sound travels a little bit better through solid than it does through air or liquid. Cool. Well done, guys. We'll go to the next question now. Which percussion note is correctly matched to the likely underlying pathology? This one is definitely very high yield because I've seen questions come up for this on the exam, and they're usually really straightforward like this. Yeah, fantastic. I don't think I'll go into this too much then. So stony dullness, liquid. Hyperresonant is too much air, so pneumothorax. Dull would be more consolidation because of a solid, and resonant is normal. Okay. It's also a good idea just to know what these actually sound like rather than knowing the words. So if you want to search it up on the internet, or if you happen to find a patient this year, you definitely will find patients next year. But if you find someone, it's a good idea to know what these actually mean in a real life context. Cool. Next question. Severe CO2 retention can be evidenced by which of the following signs or symptoms? Once you pick your response, if you just want to have a look at the other options as well and think about what they could mean. Yeah, amazing. So yellow is asterixis. So you extend your arms out, cock your wrist back, and if you have flapping, it's also called flapping tremor if you think about it in the context of another system, like classically GIT. But in respiratory, we call it asterixis, and it is because of severe CO2 retention, generally secondary to COPD, but it can be due to other obstructive causes. Redness of the face when both arms are extended above the head. That's Pemberton's sign. So that's classically because of some sort of mediastinal obstruction that's causing the superior vena cava not to be able to drain the blood away from the face, which is why you get the redness. Deviated septum. I've kind of just put deviated septum and purulent discharge together. They don't really match that well. Deviated septum is just a potential sign of obstruction, and purulent discharge could be a sign of infection. And then downwards pull of the trachea is a sign of, or is called tracheal tug. And that is classically, usually due to some sort of fibrosis that's keeping the trachea in a position while the patient is moving around the trachea, if that makes sense. So the answer here is definitely going to be yellow. Well done. Next question. 45-year-old male presents to the ED with acute onset shortness of breath. Surgery, they had a surgery a week ago. Left-sided chest pain that's worse on inspiration. There's no relevant past history. What do we think is happening with this patient? Bit of a tricky one, so have a think. Cool. Okay, so we've got pneumothorax. Does someone want to explain this one?
Yep. Sorry. This was my bad. I didn't put the answers on the Google Doc where we're making it. So the actual answer is pulmonary embolism. My bad. So what this is trying to get at is Virchow's triad, right? So respiratory symptoms always present with shortness of breath. History is super important on that. So surgery 1 week ago. If you're given surgery 1 week ago, or they've just come back from a long flight or a long drive, you're immediately thinking pulmonary embolism. Why is that? Is because in all those cases, they're stasis. So they're being immobile for a long time. The triad is stasis of the blood, endothelial injury, so which could be either through surgery or through like intravascular causes like atherosclerosis, and the third one is just being in a hypercoagulable state. And so what that means is there are certain phenomena that happen either like during pregnancy, hormonal factors, or being on certain medications like the oral contraceptive pill that make you more likely to be to have blood clots. And there's also genetic causes that you'll talk about in heme later on in the year. So surgery is your big telltale sign. The other thing is pain worse on inspiration. Now, this is something called pleuritic chest pain. There's only a few things that cause pleuritic chest pain. Pulmonary embolism is one of them, as opposed to something probably like a pleural effusion or emphysema. Those probably wouldn't change on inspiration. I don't think so. It would just be constant shortness of breath and less pain. But like a sharp pain that gets worse on inspiration is known as pleuritic. And you're already thinking pulmonary embolism, so that should make it more obvious. Yep, all good.
Amazing. Yeah, really, really. It's a good condition to kind of get used to. I think DVT might have been something you covered in lower limb. If not, you'll definitely cover it in like heme at some point, just because it's not like a very common thing, but it's also very life threatening. So if you see some patient come in with shortness of breath and they've had a history of whatever surgery, um, long flight, and potentially they may have had a really sore, painful red leg, then you're automatically red flags are going off in your mind that this person has a pulmonary embolism. It's a good one just
Yeah,
to keep in mind.
exactly.
All right. Next question, which is going to be in the picture. Jim Anderson is a previously healthy 70-year-old retired male mechanic. He presented with shortness of breath on exertion and chest pain when walking up the second flight of stairs at his home for the past 2 weeks. Jim also gave a history of 2 separate syncopal episodes that occurred while he was gardening last week. He feels otherwise well. What do we think is happening with Jim? Think about the risk factors, think about the symptoms and signs that he's showing. Well done.
Perfect. Sweet. That's great. If you just pull up the question, the show media. So what this is trying to get at is your acronym for aortic stenosis, which is SAD, which is syncope, angina, and dyspnea. So he's a Jim Anderson. He's a 70-year-old. So he's already in the older age category. Good for valvular pathologies. He's got shortness of breath, dyspnea, which is on exertion, and chest pain, angina. And he's had 2 syncopal episodes, which is fainting. So those 3 almost, if they're so buzzwordy, if they present together in a question, you're already thinking your aortic regurg or aortic stenosis, most commonly aortic stenosis. The other options we had, anemia actually presents with very similar symptoms. Like you will get shortness of breath and anemia, and you could sometimes have syncopal episodes, but chest pain is less likely in anemia. And also a 70-year-old male is not the ideal demographic that they would choose for someone anemic. Pneumonia would probably mention a fever of sorts and more like purulent, like productive cough. And panic attack, there wasn't really any mention of like tachycardia, and it was shortness of breath on exertion. Whereas in a panic attack, there wouldn't really be exerting themselves. It's more so like shortness of breath, palpitations at rest, with some stressful event as well. Yep, that's good.
Awesome.
Good job.
Yeah. What you guys will find, and you probably already have found in a lot of your exams, is like it's unlike other types of exams you would have done before, where there's one clear black or white answer. Like technically speaking, any of these could be affecting Jim at this given moment, regardless of whatever symptoms he's having. But it's a question of which one of these best fits the picture. And you have to kind of try and find the option that has the most points of evidence going for it, rather than just whichever one could be possible, if that makes sense. So it's a slight shift, but it's a good thing to keep in mind, because obviously in real life, clinical diagnosis will not be as cut and dry as you would like. Cool. Let's go to the next question. 42-year-old female productive cough, chest tightness and fever. Lung sounds distant but clear, with crackles at the left base. What are we thinking? Five seconds to go.
Sweet. I almost gave this away in the last question. Yeah, so you've got your fever and your productive cough. You already want to be thinking pneumonia, possibly tuberculosis. You want to be thinking of an infection, essentially. TB has more severe, actually, whatever. It has more severe symptoms, more cancerous type of symptoms, loss of weight, more systemic stuff. Crackles at the left base. So as we were saying earlier, pneumonia generally tends to be at the lower lung. And if you've got crackles, that's primarily because there's inflammatory cells there, which are releasing fluid, all sorts of gunk to help fight the infection, known as the inflammatory exudate. I think that's all I have to say. About the other COPD, wouldn't present with a fever, but it would have a productive cough. But it's not an infectious cause, so there's no reason for a fever. Pulmonary edema, same thing. And TB, as I said, would present with more systemic symptoms, and they probably have a history of travel of sorts in an exam question, not in real life.
Awesome. And as well with pulmonary edema, you're thinking more about like classically what's called bibasilar crackles. It's generally not, it tends not to be just on one side. It's a bilateral sort of thing that's happening, whereas pneumonia can be left or right-sided or both. So just another extra bit of evidence to add onto your list. Amazing.
Buzzword for pulmonary, actually, I'll tell it later.
Oh, sorry.
No.
Next question. So a 34-year-old man presents to his primary care physician with a 7-week history of hemoptysis. He has had a poor appetite during this time and notes that his clothes are loose on him. He has felt febrile at times, but has not measured his temperature. He denies dyspnea. He is originally from the Philippines. Again, think about what are the risk factors here, what are the signs and symptoms, and which of these options has the most evidence going for it. I think that might be all three of us, so might skip. Oh, there we go. Okay, cool.
Yeah,
TB.
sweet. Okay, TB, exactly. So TB presents with lung cancer type symptoms. So they have very similar symptoms. What makes you think one way or the other? I'll go through. So first of all, 34-year-old male, okay? He's relatively younger. You're expecting a older population, older demographic for a lung cancer of sorts. 7-week history of hemoptysis could go either way at this point. It's more gradual, it's long-term. He has a poor appetite during this time. So loss of appetite, clothes are loose, loss of weight, and febrile. So you have all these red flags going off because these are all your systemic symptoms you really want to avoid. And he denies shortness of breath and originally from the Philippines. So in an exam style question, the originally from the Philippines will set you off to a TB pathway just because everyone who presents with TB in a buzzword sense will be coming from a South or East Asian country because it is endemic over there. It sort of makes sense, but it's not always true in real life. In real life, what also will happen is if you're thinking lung cancer, you also are looking for a history of tobacco smoking. And so that's almost always present in lung cancer, but in cases of lung cancer, but it could be present or absent in cases of TB. This is getting a bit more niche, but fever in TB is lower and it has a rise in the evening or nighttime, but in lung cancer, it's sort of non-specific and it's all over the place or constant. And then if the weight loss is sudden, it indicates you're more so thinking of a malignancy, whereas if it's gradual, you're thinking of TB. Those are just some things to improve your clinical reasoning. It's not that relevant in this time. And in an exam situation, you're thinking if you have all these symptoms and then they're older and they're smoking, you're thinking lung cancer. And if they're younger and they're from a South or East Asian country, you're thinking TB. What else do we have? So cystic fibrosis, pretty sure the average lifespan of that is like 38 years old, and they would have a wide variety of different symptoms that would come up, such as like pancreatic symptoms, possibly diabetes. And cystic fibrosis questions on an exam are always like young children or babies because there's a lot of issues in that age. COPD, it shouldn't have such rapid weight loss, and also it's an older demographic. First of all, with COPD, you're also thinking smoking history, and it wouldn't be a 7-week history. It would be like years and years of build up, gradual. And I know one of the things for COPD is like the pink puffer, which is a very skinny weight loss cachectic guy, but that's a longer history. And what's the last one? Is that hemothorax? yeah, it's not relevant. That's more so a traumatic incident that has caused some sort of penetrating injury to your pleura and caused you to bleed out in there. Not particularly relevant to this question. All right, sweet. That's all. Thanks.
All right, no worries. Let's go to the next question. And well done, everyone. Just to clarify, that one person who's not putting the correct answer, and that's me. So it's you don't have to, it's okay. Like everyone else is doing is really, really well. I'm just trying to pick the wrong one on purpose. Or I'm just getting it wrong because I don't remember. You'll never know. Which answer options or option match the pathology with the correct pattern of typical pain referral? So back to anatomy, we kind of covered this last time as well. Amazing. So nice. So both of these options are actually correct. And I think this one is not too much to explain on our end, just because we covered the innovation of the different layers of like pericardium and pleura and stuff like that last time. The main thing is that the pericardium, as well as the one layer of the pleura, is innervated by the phrenic nerve, whereas another layer, so the inner layer, the visceral layer, is more likely to be innervated by intercostal nerves. Of course, there's different regional innovation, so that's something we covered in our pulmonary lectures. But when it comes to the heart, pericarditis, think phrenic nerve, so that's shoulder pain. In gastroesophageal reflux, you're not really thinking about phrenic nerve, so it doesn't make sense for there to be shoulder pain. With myocarditis, so you're thinking like heart attack type stuff, that's going to be central chest pain. That makes a lot of sense. So that's why green and blue are both correct. All right, next question. When inserting a nasogastric tube, the most distal site in or in relation to the esophagus that may resist the tube is what? All right. Yeah, so this one's a bit of a tricky one. Full disclosure, this is not a question that I wrote, so I probably won't be able to go into the details of all of the anatomy here. The main thing to remember is that the esophagus has a bunch of physiological restrictions in it. So places where you've got the diameter sort of reducing, not because of any intrinsic thing in the esophagus, it's because there's stuff around it that kind of compresses it. And I think there's a nice mnemonic that there is attached to this. I think it's A, B, C, D, E. And again, I probably wouldn't be able to remember what all those mean, but I'm pretty sure D stands for diaphragm. And I think that one is probably the more obvious one because it's going through a hole in the diaphragm. The diaphragm is a muscle, so it compresses and dilates as it wants to. That could be a potential spot where you have the esophagus becoming restricted. All right. Next question. Where would you expect a clot in the upper limbs, so a DVT, to embolize or travel to? This one is probably very, very buzzwordy. Yeah, good stuff. Nothing to explain here. DVT from the legs goes to the heart. From the heart, it enters into the right atrium, right ventricle, straight to the lungs, which is not good. So you want to be on high alert for things like this when you hit the clinics. Next question. Which part of the respiratory system does this image show? An extremely classic picture that you'll get if you ever get a histology question, which I really hope you don't because I hated histology. But if you do, if this comes up, then that's free marks because we've covered it here. Yeah, well done. Trachea. So main things you can see here are the fact that it's got this really strong ring of like cartilage, and you've got the muscle. So I think they've got the trachealis muscle, I believe, at the back. So kind of like pulling it over here, and then you've got the cartilage rings that go pretty much around the whole trachea. All right, next question. What is the correct order of layers that CO2 must pass through to be exhaled? So another histology type thing, we're looking at microanatomy. Awesome. So we've got, okay, let's see the ones that you guys have picked. So endothelium, basement membrane, surfactant, and then surfactant, pneumocyte, T1, endothelium. So in this case, the answer is supposed to be yellow, just because of the fact that, well, there's two kind of tricks to this question. The first is you need to know the layers. The second thing is it's asking about exhalation. So when we think about the layers, we think about inhalation. So when it goes from the alveoli into the blood, this time we're thinking about, okay, because it's CO2, it has to go from the blood into the alveoli. So first you have the endothelium of the blood vessel wall. You then have the basement membrane that forms part of the alveoli. And then you've got the surfactant that is secreted by the T2 pneumocytes. With the other option here, while this is actually still correct, it's only true if you're thinking about O2 going from the alveoli into the blood. So from surfactant, you've got that pneumocyte in the middle, and then you've got endothelium for the blood vessel. So hopefully that makes sense. And again, a question like this will not be as tricky as the one that's given here. It'll be more straightforward. But just to get you guys thinking about the order as well is super important. Okay. Next question. A premature newborn has difficulty breathing and is diagnosed with respiratory distress syndrome. Which cells do you think are deficient? So I'm not sure if you covered this in physiology. There might have been one slide with one line on it, but it has come up before historically in exams or quizzes. So it's just a good buzzwordy thing to keep in mind. Yeah, well done. Nothing to go over here. So remember, surfactant is the one that keeps your surface tension. Surfactant is released or secreted by T2 pneumocytes or type 2 pneumocytes. The type 1 pneumocytes are basically just there as an additional layer for diffusion to occur through. Nothing really that special for you to think about. Pneumocytes type 2 are the ones that do all the secretion work. Without the surfactant, you wouldn't have the surface tension available to keep those alveoli nice and patent. So you would have those alveoli collapsing, and hence you have the distress syndrome as described in this particular question. All right, we're neck and neck. Let's see if we can get to the finish line. Only 5 or 6 more questions to go. So it's a fairly long stem for this one. Oh, the stem hasn't been uploaded. Okay, I'll read the stem. If you guys have time, that's totally fine. Just think about it. You're going through the EMR of a patient you're clerking and read that this 17-year-old male presented to the ED with red, leaky right ear. The diagnosis is swimmer's ear. Which of the following pathogens could be the cause? Yeah, awesome. And apologies again for the fact that this stem wasn't in the image, but hopefully me describing it gave you a bit of an idea about what we're thinking about. When I say like swimmer's ear or blue ear or things like that, we're thinking immediately of something like otitis media. And if you go through the lecture on that microbiology, you will actually see that there are so many pathogens that could be the cause of otitis media. And yes, you could be thinking about your classic like Staph aureus. That's, if you're thinking about skin or something that's a bit more superficial, Staph aureus definitely is a safe bet. But you can actually also have Pseudomonas aeruginosa and Candida being part of that sort of mixture of pathogens that leads to the otitis media and the exudate that you get. The main thing is, like the thing to recognize in this question is not so much the pathogens, not too high yield. The main thing is the fact that it's a very acute type infection. And if you have that in children, it can be quite distressing because suddenly they're not able to hear. It's quite painful. So you want to treat that as quickly as possible with antibiotics. All right, next question. So hopefully this is in the image. If not, I will. There we go. 11-year-old female patient presents with an enlarged epiglottis, difficulty swallowing and drooling. The GP suspects acute epiglottitis and wishes to determine the pathogen to guide treatment, which is a fair enough thing to do. Which of the following does the GP want to avoid? This is a very good question, or at least a high yield one when it comes to exams. Yeah, so actually in this case, the answer is throat swab. And the reason why you want to avoid that is because whenever you have a case of epiglottitis, this is a patient who already has quite a restricted airway. So inflammation of the epiglottis, this person is already it's quite difficult for them to breathe already. And if you try and stick something into their throat to get a sample, you are risking further causing obstruction and making this person completely cut off their airways. So whenever you have epiglottitis in a question and it says, what should you do? Any option that says a throat swab, or I don't know, like taking a temperature from the throat, or like just anything to do with the throat, you want to avoid. The best thing you could do is actually a blood culture. or something outside of the airways themselves. Okay, hopefully that makes sense. Okay, we're almost there, guys. Which of the following infections typically leads to chronic sinusitis? Community acquired, viral, community acquired bacterial, hospital acquired bacterial, or is it a mix? Yeah, well done. Another really tricky one. And for anyone who put bacterial, that is, again, a good stab at the question. To be honest, like when it says mixed here, it probably isn't true. There's probably one of these that is a little bit more common. But the main idea of this question is to tell you that when you think about acute sinusitis, you're thinking about like classic viral type infection, because when it comes to like airway infections, viruses are the first one or the most common that you generally think about. But when it comes to chronic sinusitis, all of a sudden you're thinking about, okay, this is chronic, right? So it's unlikely to be something that is acutely caused by a virus. It could be bacterial. It could even be something like parasitic. It could be a fungus or something really strange. So it might not even be things that are on this list, which is why we've put mixed. But if you got this wrong, that's totally fine. The main thing to think about is the distinction between what causes acute sinusitis and what could be potentially causing chronic sinusitis. Okay, last three questions. This is a multi-select. Which of the following can cause lung abscesses? Well done. Yes. So actually, all of these are correct, and I'm not sure why we've got the option melioidosis. It's not actually something. I don't think it's actually something you guys would have covered. Correct me if I'm wrong. Um, the main thing here is I think melioidosis is just like a tropical infection type thing. So we're trying to get at the fact that lung abscesses can be due to some sort of infection. So in this case, we've got melioidosis, but it could also be for multiple things. So it could be bronchiectasis, which is also like secondary to infections. Septic embolization, for example, from the heart, you can have that spreading somewhere to the lungs. So that's also an infection, but also aspiration. Sometimes even in the hospital environment, when you don't put in like a nasogastric tube properly or something, and they aspirate their own gastric contents, and then that goes down into their lungs, or in the reverse, you can have that sort of like burning through in the lungs and being like a really good vulnerable place for infections to start growing and then an abscess to form. So abscesses are multifaceted, but these are some of the main reasons why you could get that in the lungs. Okay, second last question. We're almost there, guys. Last stretch. Which of the following organisms cause the majority of respiratory infections in a 30-year-old with cystic fibrosis? Again, looking at the demographics. Yeah, cool. So again, really just a buzzword here. Like if you look through the lectures, or if you look through, for example, the notes that I've put up on the Facebook, there are actually some ways that you can make this a little bit easier to remember. And there's two ways that you can think about it. One is with sort of like age. So what's most common in really young patients, what's common in middle age, what's common in really old patients, but also other like demographic factors that they could have. So where do they live? In terms of what things are around them. Do they have water plants or tanks and stuff like that around them? Are they in air conditioned rooms? Like all these things can actually affect what type of infective cause or infective agent is actually related to the cystic fibrosis that this person could be having. So if you want a bit of a reference, just have a look at those notes. So look at your lecture slides. But in this case, if you're thinking about middle-aged 30-year-old person, Pseudomonas aeruginosa, it tends to be the one that's most common. All right, and final question, multi-select. Which of the following tests can help to detect latent TB? Is it PCR? Is it, I never know how to pronounce this. I think it's Mantox or Manto, sputum acid fast, or interferon gamma release assays? Not too much to explain here. I think it's mainly just knowing the types of tests that you'd be using. I think PCR, like if we think about the stuff that we're doing with COVID, it's more of a rapid test. And generally, you have a bit of the infection already, for example, in the blood or in your sputum, whatever, to be able to actually test that. Whereas with a latent TB, that's a bit more difficult. So you need specialized tests to be able to look for those particles, or at least evidence that the TB is somewhere in the body. So in this case, one test could be Mantox or Manto, and the other one is an IG release assay. So well done, everyone. I'll just go to the leaderboard really quickly, but while we're doing that, does anyone have any questions at all about any of the questions that we've just gone through in today's quiz? I know I'm the last one here, so might not be able to give you all the answers, but I'm happy to answer whatever questions you have. And well done to everyone.